Good afternoon, everybody. And we welcome all to this academic subcommittee of the Government Medical Officers Association. Today's lecture will be the topic on HIV updates for medical officers. And today's lecture will be conducted by Dr. PIYUMI PERERA, a consultant and venereologist of the STD Clinic in Puttlam. Dr. PIYUMI is a graduate from Faculty of Medical University of Colombo, and she obtained a postgraduate diploma in an MD in Venereology from the Postgraduate Institute of Medicine in the University of Colombo. And she had overseas training at Imperial College Health at NHS Trust London. And Madam's specialization and special interest in HIV, sexual health related research, and on human T-cell lymphocytic viruses. And Madam, over to you.
Thank you so much, Dr. Charles, for that kind introduction, and for the GMOA for inviting me. So my topic today is HIV updates for medical officers. So this is my overview. I'll start off with the latest HIV trends, then HIV indicator conditions, new prevention strategies, and I'll also discuss a little bit about available services and how you can help, how the medical officers can help us to curb this HIV epidemic. So I'll start off with the background. So actually, Sri Lanka still has a very low HIV prevalence in the general population, but in certain populations and age groups, the trend of HIV cases is rising. And you all know that National STD/AIDS Control Program is the main institute for the control of STI and HIV in Sri Lanka. And we have 41 STD HIV clinics island-wide. Some are actually staffed with a consultant venereologist, and some are run by the medical officers. So to show you the importance of knowing the epidemiology, I'll move on with the trends. So now by 2020, around 38 million people living with HIV were present according to the UNAIDS. And this is what happens actually. So in the initial stages, that is in the 80s, there were no treatment. So with time, people who acquired this disease, they died. But now you must have heard that there are successful treatment for HIV. So now the number of people living with HIV is going up, and the deaths from HIV/AIDS is coming down. However, still there are new infections occurring throughout the years. And if we look into the local epidemiology, this is actually 2022 data, we estimate that around 4,100 people are living with HIV. However, only 86% of them know their status. That is, they are aware that they have HIV. And among them, only 84% are in the clinical services. So there is a gap between the number of people living with HIV and between the people who know their status. So it's very important to bridge this gap. We need to identify this 14% who are probably living in the society without them even knowing that they are having HIV. So testing is very important. So this is one of the places you all can help by suspecting and offering HIV tests. I'll move on to that later on. So we need to bridge this gap of not knowing their status so that we can get them into our clinical services. I'll briefly discuss how the numbers have gone up. So HIV cases have increased sixfold since 2010. So you all can probably see that in 2010, only around 121 people were reported. But last year, the number has gone up to 693. So yearly, it has gone up, and now probably in 2024, I think it crossed, it's over 700. And this is one of another significant finding that we found, that adult men are the major contributor to increasing HIV cases. So you can see the total number, how it has gone up, and with that, it's mainly the males who are more than 15 years of age who have been reported with HIV. The number of cases among females are more or less same and stable throughout the years, but as you can see, the contributor is the males. This is also quite a worrying factor. There is a 8-fold increase in HIV cases among 15 to 24-year-olds since 2010. Again, as you can see, the total numbers are going up. Total is around 104. And boys who are 15 to 24 years is again rising. Girls, again, more or less the same, but there is a very significant rise among the boys. So this is actually very important because 15 to 24 years is people who are still in schools, people who have just passed out A-levels and, going into new jobs or doing any vocational training, or university students. So these are the future of Sri Lanka, future of the country. So if they become infected with HIV, they have to take medication throughout their lives. So it's actually quite a burden compared with other diseases, because it's going to be 50, 60 years of treatment. So, and then even though we say that there is treatment, there are so many other issues with that as well. So prevention is actually very important, and sexual health education is also very important to curb this epidemic. And then the mode of transmission. So nearly 2/3 of men acquired HIV through male-to-male sex. So you probably heard that there are sexual practices, there is heterosexual practices, and then male-to-male sex practices. So among them, the male-to-male sex have been reported as having a higher risk of HIV acquisition. So I'll move on to a little bit of clinical facts, HIV and the indicator conditions. So what is HIV? HIV is the human immunodeficiency virus, and AIDS is something different. AIDS is acquired immune deficiency syndrome. So you can be infected with HIV, but one person might not end up with AIDS, because if they are on treatment, they will not go into AIDS. So HIV and AIDS are two different entities. And this is the viral structure. It is a RNA virus, and it has a core, an envelope, and several enzymes, and the HIV RNA strands. And it belongs to the retrovirus family and the lentivirus genus. And then the features of lentiviruses are, it has a chronic course and a long period of clinical latency. That's why even though a person is infected, they might not show any symptoms for maybe for like 5 to 8 years. And then there is persistent viral replication, and then involvement of the central nervous system. So the cellular targets of HIV are CD4 lymphocytes and monocytes macrophages. Those are the major targets which is actually important in the clinical management. So what happens? So these two figures shows what happens to the CD4 cells as well as the plasma markers of a human. So let me just try to get can I get this thing? Yeah, so the CD4, as you can see, once a person get infected with HIV, the CD4 counts drops, and then with time, our body sorts of fights back, and CD4 cell counts tries to become normal. But after several years, the CD4 cannot maintain the fight with the HIV virus. So then CD4 count starts to drop, and by that time the CD4 counts is around 200 or less. Then we call this patient as having AIDS. So if we do not treat them and if we do not catch them during these phases, they will end up dying. And the lower figure shows what happens with the viral loads and the antibodies and all. So the red colored line is the viral load. So initially there is a surge of the virus after the infection, and then because the CD4 count, the CD4s actually fight with the virus, then the virus comes to a sort of a set point, and it remains at this set point for around 10 to 12 years. So during this time, the patient may not have any symptoms as well, but after around 10 years, they might start showing symptoms. And then because the CD4 drops beyond their capacity, then again the virus starts to replicate, and then during the age stage, the patient will have a higher viral load. So this is what happens with the immune markers and everything. So what HIV does in simple words is it affects our immunity and it makes us vulnerable to opportunistic infections. So there can be several stages in HIV infection, and seroconversion illness is the first one. But the thing is, most people might not have a seroconversion illness. So you might remember, so the seroconversion illness happens just after maybe around 4 to 8 weeks of the infection. During this seroconversion illness, there can be very non-specific symptoms such as fever, maculopapular rash, cough, anorexia, arthralgia, myalgia, all the symptoms of a viral fever will be there. Some might not have any symptom at all. So it is very difficult to catch during this time unless you have a very high degree of suspicion that this may be HIV seroconversion illness. Then the patient moves on to the clinical stage 1. During this stage, they may be either asymptomatic or they can have a persistent generalized lymphadenopathy. So this is also quite non-specific and people might not think that they have HIV. Then if we do not identify them and start them on treatment, they move on to the clinical stage 2. Then they start to show a little bit of more symptoms such as unexplained moderate weight loss, recurrent respiratory tract infections, herpes zoster, angular cheilitis, and then recurrent oral ulcers, papular pruritic eruptions, seborrheic dermatitis, fungal nail infections, all these which are not managed by usual, normal management options. They may be recurrent and resistant to treatment. So what we actually see most of the time is this one. This is called the pruritic papular eruptions. This is very commonly seen at the OPDs or at the dermatological clinics. Most of our patients present with this condition, that is, in their exposed arms and legs, they get these papular eruptions following mosquito bites. So usually we tend to think, oh, this is just a mosquito bite reaction or something like that, and we just give some treatment for that. But if you have this in the back of your mind, and if you see something like this, it's always good to test for HIV and make sure the patient does not have any have HIV infection. And all this, seborrheic dermatitis, fungal nail infections, and other fungal tinnias, like, recurrent tinnias also is an indication to test HIV. Then extensive molluscum contagiosum, especially in children, is another indicator condition to check for HIV. So then again, the CD4 counts drops and then they move on to clinical stage 3. Here they will have more marked symptoms. They will have unexplained severe weight loss, which is more than 10% of their baseline body weight, and unexplained chronic diarrhea, which might last for more than 1 month, unexplained persistent fever, which we categorize as pyrexia of unknown origin, and then persistent oral candidiasis, oral hairy leukoplechias, then pulmonary TB. So this is very important. if you see a TB patient, please make sure that they have undergone HIV testing, because there is a very high risk of having HIV as a concurrent infection with pulmonary TB. And then there can be severe bacterial infections such as pneumonia, empyema, bone or joint infections, and acute necrotizing ulcerative stomatitis, gingivitis. And then another condition that we usually sort of do not think of checking HIV is unexplained anemias, neutropenias, and chronic thrombocytopenias. So if you see a patient who are having like all these conditions, and if you cannot find an underlying cause, what I feel is it's always good to check for HIV as the first line test, because rather than waiting to find another cause, excluding HIV is easier. So if you see a patient with any of these conditions, please do a HIV test. Then the most known category, that is the AIDS-defining illnesses, which is called as the clinical stage 4. So these are actually the opportunistic infections that they get. So now here, by this time, the patient's CD4 count is less than 200. So their immunity is very, very severely damaged. So now they will get signs and symptoms of opportunistic infections. So these are like, if you see this pneumocystic carini, you must do an HIV. So there's no other way around it. So it is like a must test to do. So pneumocystic carini pneumonia is a fungal pneumonia, and in Sri Lanka we usually see a lot of our patients presenting with this pneumonia. And then extrapulmonary TB. So pulmonary TB is a clinical stage 3 condition, whereas extrapulmonary TB is an AIDS-defining illness. So any patient who has pulmonary TB or extrapulmonary TB, you must do an HIV test. Then this is a sort of a vascular tumor, Kaposi sarcoma. It is caused by HHV-8 virus. So we have seen several patients with Kaposi sarcoma, and it's a AIDS-defining illness. They get all these reddish papules in their skin and the gums or in the eyelids. So, it is, if you see one, HIV test is a must. Then there are neurological conditions such as CNS lymphomas, toxoplasma, and then PML. So these are also not uncommon among our populations. We see a lot of toxoplasma encephalitis, lots of TB meningitis, and CNS lymphomas in our cohort of HIV patients. Then if you are working in a gynecological ward, invasive cervical cancer is another AIDS-defining illness. So if you see a patient, and you must do a HIV test. So this is actually quite rare now, HIV wasting syndrome. This was very commonly seen during the 80s and 90s, when ART was not available. But now we do not see them, but there can be AIDS patients. So even last year, around 16% of our cases were reported at the AIDS stage. So it's not that uncommon, but HIV wasting syndrome, we do not see it much commonly. But if you see a patient with lots of wasting and very thin and very low BMI, please do an HIV test. There can be other skin conditions such as extrapulmonary cryptococcosis, which can come on phase, and then there can be brain involvement as well. And then esophageal candidiasis. So oral candidiasis is usually a clinical stage 3 condition, whereas esophageal candidiasis is a AIDS-defining illness. Then eye-related symptoms are cytomegalovirus infections. There can be retinitis, and CMV can also cause infection in the gut, lungs, and the CNS as well. Then, as I mentioned, there can be there can be diarrhea such as isosporiasis and cryptosporidiosis, These are actually, if you see a patient who are having, unexplained chronic diarrheas, you have to have the suspicion of HIV and do a HIV test. So as I've mentioned HIV testing a lot of times now, I'm going to move on to the specifics of it. So we have two types of testing, screening as well as the confirmatory tests. So you may have heard that we have a HIV ELISA, so it's a lab-based test. Particle agglutination is also a lab-based test. So that is what we usually, we did for the, until quite recently, but now we move on to doing rapid tests. So the benefits of doing a rapid test is the turnaround time is very quick. We can get the results within 20 minutes. And then there is another test called HIV self-test, where the patient or the client can do it by themselves. It's just a test where they just have to use the saliva or the fluid of their mouth. So it is called the Aura Quick, and they can do it by themselves and get the results if they do it according to the instructions. So if one of these screening tests become positive, then we do the Western blot or the confirmatory tests. And depending on that, we decide whether this patient is infected with HIV. Then for disease monitoring purposes, we do the DNA PCRs and RNA PCRs. And it is not exactly a confirmatory test, but in certain conditions, such as if we suspect a female who is pregnant, and if we cannot sort of have a clear idea with all these screening tests, we might have to do the PCR test in a pregnant female. Then there are several HIV testing modalities and settings. You all know that we do it at the STD clinic. So for the clinic attendees or partner screening or anyone who's interested. And then the STD staff do outreach testing, especially for the key and vulnerable populations. We do outreach clinics and, online outreach as well. And then ANC clinics, we offer HIV screening for all the pregnant mothers. And then, as I mentioned, all TB patients must undergo HIV screening. And then there is donor blood testing and then hospital-based testing according to the symptoms. Then there are visa screening, and as I mentioned, there can be HIV self-testing and testing in special situations. And you may have heard of voluntary counseling and testing. So the patient or the client comes to us and they volunteer to have a test. So from this lecture, what I want to emphasize is on the provider-initiated testing. That is you. We are the providers. We can offer HIV tests for anyone we think that might need. So initially there used to be a counseling session before offering a HIV test. But now you don't have to have a very extensive counseling or informed written consent. You just have to offer the test. It's just an informed testing. You can say that your symptoms might suggest us that there is an underlying condition. So for that, we have to do this HIV test. So that's enough. You don't have to get it signed, or you don't have to counsel them for for hours and hours. It's just a very easy way of offering, providing initiated testing. Or if you think that there is a patient who might need HIV test and you are not very comfortable in discussing that, you can send the patient to us, to the STD clinic, so that we will discuss the issues in testing and we will provide the HIV test for the patient. And when we talk about the HIV test, there is something called the window period. So window period is the time after exposure to HIV when antibodies are developing and may not be detectable by a test. So the length of the window period depends on the type of the HIV test used. That is, let's say I got infected today, and if I get tested tomorrow, nothing will be shown in my blood because it takes time for the antibodies to develop, or for the antigens to be shown in the blood, or even the DNA particles to be shown in the blood. So all this depends on the type of test that we are using. So for a rapid antigen antibody test, that is what we usually do now. For that, it takes around 18 to 90 days after exposure for it to be positive. And then if it is antigen antibody lab test, it might take around 18 to 45 days. If it is only antibody test, it might go up to 90 days for it to be positive. The test which will show a positivity quickly is the NAT test, that is the PCR test, and it can detect HIV by around 10 days after the exposure. So now, as I mentioned, we do the 3 rapid test algorithm according to the WHO recommendation. So, and if the 3 rapid tests are positive, we usually do not, for the moment we are doing the Western blot, but we plan not to do the Western blot in the future, because then it will take more time to diagnose the patient. So as I mentioned, the rapid test is only 20 minutes and we can give the results then and there. And in this self-testing, which is done from the oral fluid from the gums, it has 93% sensitivity and 99% specificity. And this self-test can be ordered online. So we have this website called 𝗦𝗨𝗕𝗘𝗦𝗪. So if one person goes to this website, they can order a self-test and they can get it to the address that they provide with 100% confidentiality. So we've introduced all this so that people will take HIV testing, and we need to, as I mentioned, fill that gap of people who are not aware of their HIV status. And then we also do the ANC screening in the first trimester for all pregnant mothers. So HIV treatment, there have been lots of changes in HIV treatment throughout the years. So the first HIV patient was reported in the 1980s, so now it's 40 plus years. And throughout these 40 years, there have been so many drug classes, so many drug combinations which have been tried and which have been successful, and some have been failed. So I'm not going to go into all the details, but now we are using a combination of treatment, and in future there will be, and in other countries they are using long-acting formulations, but in Sri Lanka we don't have such facilities at the moment. But with time, probably we will also get long-acting formulations, which will be very easy for the patient. So, in the most simple way, I will say about the ART management. ART is the antiretroviral treatment. So, all the PLHIV, that is people who live with HIV. So that's actually the terminology that we use, people living with HIV. So we test them, and if one person is positive, we treat them then and there. So now we have this concept of same day treatment. We can start treatment on the same day if the patient is willing, and if we think that they do not have any other underlying opportunistic infections or any other issues. So most of the time now we offer same day treatment, and it is actually a 3-drug combination. And first line in Sri Lanka is tenofovir disoproxil-fumarate, lamivudine, and dolutegravir. So this combination is now called as TLD, and this is the one that we offer for our patients as the first line. But there are many more drug regimes depending on the situation, because there are some conditions where we cannot offer this first line, and we'll have to mix and match the drugs we have and develop a regime for them depending on their clinical scenario. So the best thing is to liaise with a consultant venereologist once a person living with HIV is diagnosed, to start treatment. Common side effects that we usually see are like tenofovir related nephropathy and bone mineral density loss, dolutegravir related weight gain and liver injury, and there can be GI symptoms as well. So a little bit about TDF nephropathy. It's usually a proximal tubular nephropathy, and we monitor with the UFR and we look for the albumin and then serum creatinine and we calculate the EGFR. And depending on the EGFR and the presence of proteinuria, we have to change to alternative ART regimes. I'm discussing this a little bit just because we see a lot of patients who are having tenofovir related nephropathy. Maybe because in Sri Lanka, there is an underlying kidney issue in the general population, which might be enhanced by this with our ART. So this is what we actually mainly we are concerned with now. They are having this nephropathy. Then there is another issue that there can be drug interactions. So as I mentioned, if the person is on tenofovir, we have to be cautious when we are administrating nephrotoxic drugs. And then most of the time, the patient might be on anti-TB. And if the patient is on rifampicin, this reduces the dolutegravir levels. Then we have to double the dose of dolutegravir. And then some of the antacids, not some actually, antacids reduce dolutegravir levels. And so we have to explain to the patient about the need to space out dosing. So what we use is the HIV Liverpool drug-drug interaction website, where it clearly gives you the advice on what to do. So what we do is we usually put the HIV drugs and the co-medications and check for drug interactions. And then it advises us on what to do, whether to change the drugs, whether to increase the doses, and whether to look for alternatives and all that. So it's quite easy. So if you are a general practitioner, or if you are like, maybe if a HIV patient comes to you for another, let's say a respiratory condition or any other condition where you might have to prescribe a drug, you can, if the patient disclose that they're HIV, you can ask for the, ask what they are on. And then you can put the medication that you are planning to give and the HIV treatment on this website and check for drug interactions and prescribe accordingly. Then this is actually one of the most important game-changing concept which was found through research, that is undetectable equals untransmittable, U equals U. So if a patient, HIV person who's living with HIV is on treatment, and if their virus level goes to undetectable levels, that means he cannot transmit the virus to another person sexually or through pregnancy. So that this has become a very, very important concept, because now if they are taking their medications properly every day throughout their lives, and if the virus is successfully controlled with undetectable viral loads, they cannot transmit it to another person. So that is actually very important, because now they now even have, like, sexual activities without condoms if they are undetectable, and they can have pregnancies and have HIV negative children because of this concept. So moving on to HIV prevention, there are several methods, traditional methods such as safe sex counseling, condom and lubricant promotion, and the newer ones are the pre-exposure prophylaxis and post-exposure prophylaxis. I'll move on to the pre-exposure prophylaxis. So pre-exposure is something like, contraception. So we give it beforehand so that the person who is at risk for HIV will not get HIV. So we've identified some populations who are at risk, such as the males who have sex with males, transgender women, intravenous drug users. So for such patients, and serodiscordant HIV couples if the HIV positive partner is not on treatment. So in such cases, we assess their risks and we offer them pre-exposure prophylaxis. So in Sri Lanka, this is available throughout the STD clinics. It is available free of charge. So there are two types of regimes, that is the daily PrEP or event-based PrEP. It depends on their frequency of sexual activities. So then we discuss with the patient and decide on which course to give. In other countries, there is something called long-acting injectables. This is given once a month, and that is also used as pre-exposure prophylaxis. Then there's another concept, another prevention strategy called post-exposure prophylaxis following sexual exposures. And it is similar to the PEP that we provide following a occupational exposure. So this can be offered for people who have undergone sexual abuse or any high-risk sexual exposures, but it must be taken within 72 hours of exposure. Otherwise, the effectiveness is not there. However, if we start it, it has to be continued for 28 days. So as we all are medical officers, I would like to touch on the post-exposure prophylaxis following occupational exposure as well, because we see a lot of doctors coming following needle prick injuries, mucosal splashes, and what to do. So this is the estimated median risk for HIV. So if we consider the sexual exposures, receptive anal intercourse has the highest HIV risk. And if we consider the occupational exposures, needle stick injury has a 0.3% risk and mucous membrane exposure has a 0.09% risk. So the infective material are blood and other body fluids such as spinal fluid, peritoneal fluid, pleural, synovial, amniotic, vaginal and seminal secretions, and breast milk. However, these are not infectious in the absence of visible blood, that is urine, saliva, tears, sweat, and feces. You probably know these. These are the blood-borne infections. So hepatitis B has the highest risk. There's a 30% risk of catching HPV following occupational percutaneous exposure. HCV has a 3% risk, and HIV has the lowest risk but has the highest stigma, that is 0.3%. I'll briefly discuss the steps in management of occupational injury. If you undergo a needle prick injury, you have to manage the wound. Then you must come to a STD clinic for the assessment, counseling, and prescription and follow-up. So in the wound management, what we advise is to gently wash the wounds with soap and water, not to scrub it and not to squeeze. And there is no benefit of applying an antiseptic or a disinfectant. And if it is a mucosal surface exposure, we advise to irrigate with sterile saline or clean water. Then you all probably know that there is a accident reporting register at the wards or the theatre or anywhere you work. So the documentation of that exposure is very much essential. And this needs to be informed to the infection control unit. And we also have a documentation process at the STD clinic. So if you come to us within 72 hours of the exposure, we will assess you. And we can provide post-exposure prophylaxis within the 72 hours window. After that, there is no evidence that there is protection from post-exposure prophylaxis if the 72-hour window is gone. So the most important thing is, if you know the patient, you had the HIV, you had the needle prick or the mucosal exposure, you have to bring a sample of the source person as well as yourself to the STD clinic. So we do the rapid test on both samples. If the source sample is negative, we might not give post-exposure prophylaxis depending of the possibility of being in the window period. So to assess the window period, we might need to get a sexual history from the patient. But if we are sure that this is unlikely to be in the window period, and depending on the exposure, after counseling, the healthcare worker can decide whether to take the post-exposure prophylaxis or not if the source is negative. If the source is positive, again we will check whether the patient is on ART, if it is a newly diagnosed patient, or if the person is on ART, whether the viral load is undetectable and all that. And depending on that, we will offer post-exposure prophylaxis. So that is what happens if you have the patient with you, but if you don't, if you got a prick injury from a needle lying around, so usually we do not offer any post-exposure prophylaxis because one thing is the HIV prevalence in the general population is still very low in Sri Lanka. And the other thing is when HIV is exposed to air or sunlight, it gets destroyed. So if the needle has been lying around for some time, probably you will not get HIV through that needle prick exposure. So anyway, if you undergo some sort of occupational injury, please come to the STD clinic and talk to a consultant venereologist or the medical officer there, and we can discuss the next steps. So usually the high-risk exposures are, if we assess them depending on the injury, the body fluid involvement, and the severity of the injury, such as the depth, whether there have been visible blood, and so on. And we do the rapid test, as I mentioned. If it is positive, we will start post-exposure prophylaxis. And if it is negative and recent high-risk behavior is, if you think that there is recent high-risk sexual behavior, we can consider post-exposure prophylaxis. And if it is negative and no risky behaviors, probably there might not be an indication for post-exposure prophylaxis. And another thing related to HIV I'd like to touch upon, if you are joining from obs wards or gynae wards, you all must be knowing that Sri Lanka has obtained the WHO certification for the elimination of mother-to-child transmission of HIV and syphilis in 2019. And we are still undergoing revalidation, which started in 2024. So that is why we are offering all the pregnant mothers HIV testing at their initial ANC clinic visit. And if you see a person who has undergone stillbirths or miscarriages and has not undergone HIV test, please offer HIV test, because stillbirth or the miscarriage can be due to HIV per se as well. So if you are working in an obs ward, please check all the antenatal records and to see whether the mother has undergone the HIV test and the syphilis test. If the mother has not undergone, please inform the STD clinic as soon as possible. And we've come across pregnant mothers who are diagnosed with HIV at labor. So they've not been to antenatal care during their the first or second trimester, but they present to the labor. And when they do the HIV test at labor, they are positive. So then it is very important to inform the relevant consultant venereologist of that district and the consultant pediatrician. So that mother needs to be started on antiretroviral treatment as soon as possible. And then, because they are at a very high risk of transmission of HIV to the baby should not be breastfed. And mother is then given medicine to suppress breast milk. And once the baby is born, we start the baby on post-exposure prophylaxis as well, and we take blood for HIV testing. And if you are working in labor rooms and all, you might know that we usually keep the medications at the labor room for emergency initiation as well. If not, please discuss with your district consultant and arrange all this so that you are ready for an emergency. So how can you help? So I've discussed actually most of the things that the ways that you can help. The most important thing you have to take from this talk is to identify HIV indicator conditions or AIDS defining conditions. It's easy to identify the AIDS defining conditions, but the other ones that are present in the clinical stage 2, clinical stage 3, they are very non-specific. You might not even think that this patient is having HIV. And now you all must know that most of our patients are quite educated and they are in quite good professions. So you cannot assume by looking at a person, this person is not at risk for HIV. So it is very important that you have to have quite a good clinical acumen and decide to do a HIV test, even if all the other factors are not very favorable towards HIV. So that is very important. And please know that there is no need of pre-test counseling. You can just offer the HIV test and do it. And if the patient refuses, then yes, of course, you cannot do it. You can then send the patient to us. So we will discuss and arrange the test. And then you must make sure all antenatal mothers have undergone the HIV testing. And if needed, to repeat the testing at third trimester if you think that this woman is a high-risk woman. And be aware of the availability of occupational post-exposure prophylaxis as well as the post-exposure prophylaxis following sexual exposures, because the important thing is these medication must be started within 72 hours of exposure. Otherwise, the protection is not there. And the other most important thing is to achieve zero stigma and discrimination at all settings. Because if these people go into hiding and if they do not come into our services, their virus, we cannot control their virus. But at the same time, they might not change their behaviors. So what happens is they are not taking the medication as well as they are having sex, and HIV will be transmitted in the society. So if we have zero stigma and discrimination, they will not be scared to come to the health services. So that is why we always advocate for zero stigma and discrimination, because if they are protected, all the society will be protected. So the UNAIDS targets are ending the AIDS epidemic by 2030. Sri Lanka is also working towards that goal. So I think all the medical officers can help us by identifying HIV indicator conditions and offering HIV test at the initial stage so that there won't be any missed opportunities. So stigma is more harmful than HIV because, as I mentioned, if they go into hiding, HIV spread will be more in the society. There are some websites you can use. So the one above is the National STD/AIDS Control Program website. There are so many resources like the publications, annual reports, guidelines, and then statistics. You can get all the data from our website. And then the other one is the knowforsure.lk. You can even introduce these to your clients, your patients, and they can assess their sexual risk, and order self-test kits or put appointments to STD clinics through the website. And also they can sort of do online chatting and then get information from our service providers. So, I mean, virtual outreach is done through this website, and it's very easy and people are using it. So as doctors, please be aware of these websites so that you can offer these to people who are in need. So that's all for my talk today, and these are my contact details. You can send me a WhatsApp or you can send me an email if you have any questions. And like if you have any problems in managing patients, or if you have any issues in, offering HIV tests, all that, you can discuss with the district consultant or even with me, and we will help you and guide you in managing HIV patients. So thank you so much, and I thank the GMOA Academic Subcommittee for inviting me to do this talk today. Thank you.
Thank you, Madam, for your wonderful information and sharing your knowledge with us. And it was a wonderful presentation with a lot of insight. And by our doctors, we have a few questions, Madam. One question is, how long need to get post-exposure prophylaxis in a prick injury?
That is, if we start the treatment, I suppose.
Yeah.
Yeah. So the usual regime is for 28 days. They have to continue it for 28 days.
All right. And the second question, madam, HIV combo test and VDRL test are negative with risk patients. When do we need to repeat the test? Are there any other tests suggested by you if the VDRL is negative?
So VDRL is actually done for syphilis. It's not for HIV. And if the VDRL is negative anyway, we usually do VDRL and TPPA. That is the confirmatory test for syphilis. So usually we advise to do the VDRL as well as TPPA if you suspect syphilis. And for HIV combo is quite good actually. It has the antigen as well as the antibody. So the window period is starts around 2 weeks time. So if you think that the patient is high risk, you can repeat the test after 2 weeks and see. And if it is also negative, please refer to the patient to us. Then probably we can arrange other testing depending on their clinical history.
All right. So we'll go for the last question, madam. Can HIV-2 be detected using the current HIV screening test?
Yes, screening test we can detect. HIV-1, 2 antigen antibody is the screening test that we do. So yes, HIV-2 can be detected, but we cannot say differentiate from that test. We will have to go for other advanced testing to differentiate whether it's HIV-1 or 2, but 2 will be detected.
All right. And thank you very much, madam, for your wonderful information and for spending your wonderful time with us and sharing this great information with among medical officers with the Government Medical Officers Association sub, and would like to thank you under the sub academic committee for your time, and thank you everybody for participating. Thank you.